Hello, ladies, gentlemen, and distinguished guests. My name is Mary Helen Pombo, and as a fellow at the Center for Health Policy at Imperial College London, I lead on the Leading Health Systems Network program. The LHSN is a collaborative network of healthcare leaders and organizations working to improve health service delivery. Based here at Imperial College, LHSN works in partnership with the World Innovation Summit for Health, otherwise known as WISH. Today, I'm pleased to welcome you to this LHSN webinar titled Adapting the United States Antimicrobial Stewardship Program Guidelines to Build an Economic Evaluation Framework for Chinese Hospitals. I'm also happy to announce that this session is co-hosted by the ISPOR Asia Consortium. ISPOR is a professional society for health economics and outcomes research with the mission of promoting excellence in this field to improve decision-making for health globally. This society is a multi-stakeholder organization with over 20,000 individual and chapter members worldwide. The ISPOR Asia Consortium is a member group comprised of professionals interested in the organizational mission in Asia Pacific and globally. The consortium provides a platform for information sharing and institutional collaboration on HEOR and health policy, facilitating professional networking opportunities through scientific activities and global ISPOR initiatives. Now, before getting into the content, I welcome you to interact with others listening to the session and tweet key messages by using our Twitter hashtag for this event, hashtag LHSN webinar, along with other suggested hashtags on the presentation. With that, I'll introduce our speakers who we have the great pleasure of hosting. Our first speaker, who will be providing an introduction to antimicrobial stewardship programs, is Dr. Seema Haider, Senior Director and Group Leader of Pfizer Essential Health and Health Economics and Outcomes Research at Pfizer in New York City. Seema is also a visiting professor at the Public Health and Health Economics Research Center in China's Hebei University and an international advisor to the ISPOR India chapter. Seema has completed an MSc and PhD in Social and Preventative Medicine from the University of Montreal with a specialization in pharmacoeconomics. Now, our second presenter today, Emily Chen, will be exploring antimicrobial stewardship programs in more depth within the Chinese context. Emily is a health economics and outcomes research manager at Pfizer Investment in Beijing. She brings more than 6 years of experience in the field of health economics and outcomes research and has specifically worked on economic evaluation of healthcare programs, for example, antimicrobial stewardship and city immunization programs. Emily also completed 2 Masters of Science, one in Medical and Pharmaceutical Drug Innovation from Groningen University, and another in International Healthcare Management, Economics, and Policy from SDA Bocconi. Our final presenter, Dr. Cindy Gao, who will present on building an antimicrobial stewardship program economic evaluation framework and model in China, is the principal Asia Pacific regional lead at PharmaMerit International in the US. She brings more than 17 years of experience in health economics and outcomes research consulting, and she completed her PhD in pharmaceutical economics and health policy from West Virginia University School of Pharmacy. Now, without further ado, I'll turn it over to Seema.
Thank you. And hello, everyone. Welcome to our webinar on AMS programs. So before we get into the depth of AMS guidelines and programs, let's ask ourselves why. Why are we talking about antimicrobial stewardship, and why are we concerned with AMS programs? Well, first of all, antimicrobial resistance is on the rise and has become an important public health issue for countries around the world. What does this mean? Well, this means that it's becoming increasingly difficult to manage microbial infections with medicines that we have available to us now. So this is leading to substantial impacts on mortality and costs associated with treatment and with management in the face of resistance. In 2014, O'Neill estimated that by the year 2050, antimicrobial resistance will be responsible for over 300 million premature deaths and will negatively impact economic output. So if we could go to the next slide. So what does that mean for us? So what this means is that we have to do something to manage this. And we need to educate all of our stakeholders on the impact of resistance and on the appropriate use of antimicrobials. Antimicrobial stewardship programs are one way that we can promote the appropriate use of antimicrobials to not overuse, misuse, and abuse these antimicrobials. What are the benefits of an antimicrobial stewardship program? Well, the benefits include providing the right therapy for the right patient at the right time, improve patient outcomes with faster and more complete infection resolution, and then finally, reduce costs related to cost savings from cost of antimicrobials, hospital stays, and treatment of resistant infections. So let's take a closer look at the benefits of AMS programs. So primarily, AMS programs encourage the use of appropriate antimicrobials. Many studies until today have shown that a well-structured and well-implemented AMS program in a hospital leads to a decrease in AMR and AM use. The numbers that you see here are from 2 meta-analyses looking at such a program. And as you can see, that a result of an AMS program, there's a 15% increase that was seen with desired practice. A 19% decrease was seen in antibiotic consumption. A 27% decrease was seen in the consumption of restricted antimicrobials. And there was a decrease of 1.95 days of treatment and a 2 to 10% decrease in MRSA, imipenem, and ESBL resistance. So AMS programs also impact patient outcomes, and they do this by reducing the length of stay a patient stays in the hospital. They reduce hospital readmissions. They also reduce mortality, and they reduce the number of patients needing mechanical ventilation. So these are all benefits in terms of patient outcomes. So in addition to this, AMS programs also reduce the total cost of care. How do they do this? They do this by reducing expenditures associated with hospital length of stay and post-operative infection. So if we look at expenditures related to antimicrobials, we see that a meta-analysis indicated a 34% reduction in antimicrobial costs following ASP introduction. And a global literature review showed that between 10 to 40% reduction in antimicrobial costs was seen with proper antimicrobial use. There was also cost savings related to reduced length of stay, so an average of 2.9-day decrease in LOS, which saved $601 per patient, was seen. And in terms of cost savings related to antibiotic resistance post-operative infection reduction, we saw that the proportion of resistant antibiotic strains in post-operative infections in a tertiary referral unit decreased, also lowering costs by over 50% per patient. So considering the importance of antimicrobial resistance and the need to educate stakeholders, the British Society of Antimicrobial Chemotherapy, or the BSAC, and the University of Dundee have developed and launched a free 6-week online AMS course called the MOOC, which is available in Mandarin, in Spanish, in Russian, in Portuguese, and in English. Since this course was launched in 2015, over 50,000 people have taken this course. And metrics from this course show us that 91% believe that the course exceeded expectations, 89% felt that the course met or exceeded their overall expectations for an online course, and that 90% found the course engaging or very engaging. And this course is continuing this year and then into next year. In addition to this, the BSAC and the University of Dundee have also developed an AMS eBook. And since the launch of the eBook, there have been over 10,000 registered downloads from learners in over 130 countries, authored by 39 authors from around the world. And once again, from the metrics, you can see that 31% downloaded both the PDF and the EPUB, 68% downloaded just the PDF, and 1% downloaded just the EPUB. So this resource has just become available recently. And once again, we'll watch in the future as to how this proceeds. So in summary, let's talk about the benefits of ASP. What do? They help to control and prevent antimicrobial resistance by promoting proper use of antimicrobials. They improve patient outcomes with reduced length of stay, hospital readmissions, and mortality. They encourage appropriate antimicrobial use with decreases in antimicrobial use and antimicrobial resistance. And they also enable cost savings. We also have several great educational initiatives that are available. The AMS MOOC and the eBook are both online resources from BSAC, and we also have the checklist for hospital antimicrobial stewardship programs. So with this, we'll move on to our next section, and I'll turn it over to Emily.
Thank you very much, Seema. Hello, everyone. Thank you for joining our webinar. My name is Emily Chen. I work in the HOR team at Pfizer China supporting anti-infectives. I'm based in Beijing, China. Following Seema's talk on ASPs in general, I will introduce the ASP development in China, leading to why we needed an economic evaluation framework for ASP in China and how we did it. So if we first take a look at a few out of many data on antibiotic misuse and resistance in China, we can see that on average, each Chinese person consumes 138 grams of antibiotic a year, which is 10 times of the US average. And many patients receive unnecessary antibiotic treatment. For example, antibiotics are prescribed to 75% of patients with seasonal influenza and 80% of inpatients. But the WHO recommendation is only 30%, and 97% of surgical patients receive antibiotics as well. And a very recent paper published this month in Lancet Planetary Health showed that the antibiotic resistance in China is between moderate to high severity. If this situation continues, prevention and treatment of infections will become less effective. This will harm public health in China as well as worldwide. So to address this issue, also as an effort in response to WHO's Global Action Plan to tackle antimicrobial resistance, National Health Commission of the People's Republic of China, which is equivalent to MOH in other countries, launched the National Action Plan to fight against antimicrobial resistance. And among the goals, as you can see here, to implement an ASP in all hospitals was clearly stated. So next slide, please. And in the table on the left side, these are the tactics in the action plan. Among the 9 action items to curb AMR, there were 3 items, number 4, 5, and 6, that are relevant to efforts in the healthcare setting. And they are the fundamentals for establishing a systematic and sustainable approach to contain AMR, including first, constructing a well-defined and implemented ASP, and second, develop reliable resistance surveillance networks, and third, capacity building for key professionals involved in ASPs. In response to these development requirements in China, Pfizer China, as the company with a strong portfolio of life-saving anti-infectives, proactively collaborates with the China MOH to accelerate the ASP development to ensure that each patient in China on antibiotics gets appropriate and optimal therapy. This is the mission for this collaborative project, which we call Navigator. So specifically to support the previous slide. Yeah, thank you. Specifically to support ASP development, we keep exploring the optimal ASP operational model and provide support from theory to implementation in hospitals. And secondly, in relation to resistance surveillance networks, we established an over 10-year collaboration with prestigious teaching hospitals and the MOH to do antibacterial, antifungal, and antimicrobial resistance surveillance networks across the country. For example, the flagship CHINET has collected more than 153,000 strains last year in 2017, and in total, more than 757,000 strains have been collected so far. As for capacity building, we've been providing periodic and tailored trainings to ID physicians, clinical pharmacists, microbiologists, and infection control professionals. These are the face-to-face trainings, and they have reached hundreds or even thousands of HCPs and cover more than 30 out of 34 provinces in China. And having set the goals and strategies at national level, we realized that the administrative pressure from government is to establish ASPs is far from enough to have well-implemented ASPs across the country in order to really produce a positive impact on slowing down AMR, antimicrobial resistance. Since ASPs require rigorous and cross-functional actions at a given healthcare facility, say a hospital, it's very important and valuable to let the hospital be aware of its overall benefits. And this will justify the hospital's investment in it and then motivate the hospital to continue doing ASP. Only when a hospital clearly sees the benefits of an ASP can we move closer to sustainable ASPs running at national level. But it's not going to be easy or straightforward to measure the benefit associated with an ASP. If we look at the required investment in that red box, an ASP includes a bundle of integrated intervention, for example, system development and maintenance, increased workload or workforce, trainings, and other overhead investment. And the evaluation of any single component here does not capture the total cost of care. But it's just this total healthcare cost and resource utilization that should be a good target for our evaluation. And again, on the benefit side in this green box, there are also many individual target components that should be evaluated. So how do we take into account all these investment and benefit components when we measure an ASP in a hospital? And sometimes we even want to compare the efficiency of ASPs between hospitals. The potential barrier for this, for the comparison, is that the different ASP operational models might be adopted in different hospitals. And there are various ASP interventions that can be taken. For example, if we look at these publications, some ASPs were microbiology driven, some were pharmacists or even nurses driven. So is it possible to compare the efficiency of ASPs across hospitals for the purpose of identifying an optimal operational model? Next slide, please. To better explain what I mean by ASP outcome components, I'm showing an example from a Chinese study which analyzed both clinical and economic benefits in terms of antibiotic consumption and costs, duration of treatment, and length of stay. The message of this is very clear that an ASP improved patient care through increased appropriateness of care, resulting in reduced length of stay and reduced healthcare resource utilization. But if we ask this question further, how to quantify these benefits using a single metric so that the hospital can know if the benefits are worth the investment? And if the hospital decides to invest more to ASPs, how to maximize its value? Will it be sustainable for the hospital? So how do we generate the best possible evidence to inform hospital decision-making on ASP investment in terms of funding and program design and implementation? And we think that standardized measurement is as critical as they are for measuring the quantity and quality of antimicrobial use in a stewardship program. We think that an ASP itself needs to be measured using a common agreed and easy to understand approach in order to inform decision making. So next slide. And one of the good methods is to conduct a so-called cost-benefit analysis, which transforms the investment and outcomes into monetary value for direct comparison. And for the purpose of simple data communication, we can calculate the net benefits of an ASP in monetary value and then divide it by the investment put into this ASP. And by doing so, we get the return on investment, the ROI. And this is the Dutch study showing proven value for money with a 700% ROI of their ASPs. The figure on the left side showed the interventions they've used in their ASP for 1 year with very good clinical outcomes of reduced antibiotic use or changed antibiotics and switching patients on IV to oral 1 day earlier. And when we look at their ROI, launching an ASP requires a substantial investment at the beginning, but after a few months, saving on antibiotic use started to offset the investment, resulting in a 7-fold ROI in only 1 year. And China is in the exploring phase of ASP development, so we're keen to know how the ROI is like in Chinese hospital ASPs. If the cost-benefit analysis helps us recognize the gap between our local practice and the international best practices, it will be very helpful for us to make targeted improvements. So now I'll hand over to Cindy to introduce how we embarked on the journey of evaluating local ASPs. Thank you.
Okay, thanks, Emily. My name is Cindy Gao, and I'm from Merit International. As a continuation of Emily's talk, I'm going to present a project example for building an ASP economic evaluation conceptual framework and model for China. So currently, the evidence on economic benefits of ASPs largely focuses on US and EU5. So the knowledge on ASP benefits in China is really lacking, and currently there is no established ASP evaluation framework in China. Therefore, Pfizer and Merit International has collaborated to initiate a project that aims to evaluate the value of ASP in China. Specifically, the aim will be achieved by 4 phases. First, we adapt the CDC guideline with the feedback obtained from Chinese experts to build a conceptual economic evaluation framework. And in second phase, we constructed an economic model based on the conceptual evaluation framework and also populate the model with published data. And in the third phase, a user-friendly graphic user interface, so-called GUI tool, was developed to help us visualize the economic model and collect data inputs. And finally, in the current phase of the study, we'll collect the hospital data with the GUI tool and finalize the economic model and return on investment analysis that assess the cost and benefit of implementing ASPs in Chinese hospitals. So this is still ongoing for the last phase. All right, specifically at the first step, we developed a questionnaire based on the core elements of hospital ASPs defined in the US CDC guideline. 4 key sections were included in the questionnaire that was used in the face-to-face interviews to the experts from academic tertiary grade A hospitals located in 9 major Chinese provinces or cities in late 2016. And the four sections in this survey included project introduction, which includes information on the project background, US CDC ASP guidelines, and the UK ARHAI model frameworks, and the project and questionnaire objectives and the embedded key full text references. And the proposed conceptual framework of ASP evaluation model for China that summarize the key components proposed for China ASP evaluation model design. And then a checklist of core elements extracted from the CDC framework that ask KOLs if each element is implemented in their program, and if not, whether they think it should be included. An open question regarding other measures not mentioned on the list was included. So, and the last one is the hospital and patient population information that asks preliminary questions that collect ASPs related personnel and resource utilization data and outcomes. This slide lists some key findings from the interviews. The experts believe that all ASPs had or should have established practices for providing treatment recommendations for this for those listed common infections. Additionally, practices should be developed for antibiogram updates, ASP education and training, and prescription documentation. And also all the Chinese experts agreed that other resourceization and outcomes measures to be included in the Chinese ASP framework were antibiotic ICU use, reduced IV days due to earlier switch from IV to oral antibiotics therapy, and hospital on-site infection rates, and restricted antimicrobial drugs use. Okay, here are some key differences we identified between Chinese real-world ASPs and US CDC ASP guidelines. For example, the role of pharmacists in China overall is very limited in hospital clinical decision-making process. And pharmacists' involvement in routine participation in IV to oral switch programs or antibiotic dose decisions is none or very, very limited. And also susceptibility tests before antimicrobial drug use were usually only conducted when patients with serious infections. And antimicrobials may also be administered prior to hospitalization based on the survey of the physicians from the survey. So it's very hard to track their previous use of antimicrobials. And given the very large workload, work burden of Chinese doctors, especially in the big hospitals we interviewed, the review of antimicrobial appropriateness within 48 to 70 hours after initial orders were very limited or not feasible based on some of our experts' comments. So experts commented that clinical pharmacists' responsibilities should be expanded and information and data system need to be upgraded. All right, other comments related to ASPs received from this Chinese expert survey included, for example, C. diff infection and skin soft tissue infections are not really common in China or have not been drawn much attention. So no hospitals we actually surveyed has specific intervention in practice for those two infections. And also a lack of incentive to implement and maintain ASP was also reported by the interviewed experts as an obstacle to ASP uptake. Because under the current reimbursement system in China, a decrease in antibiotic use resulting in decreased antibiotic sales could actually decrease hospital income revenue. And also some ASP functions can be part of daily activities and not necessarily only conducted within our ASP, according our experts interviewed. And also it is important to mention that almost all experts commented that in China, it is more likely that there is no increase in labor cost if no extra full-time employment is created to implement ASP. Instead, staff would be assigned more workload associated with ASP implementation. That means people or doctors get busier without extra pay. So unless a new position is added, labor cost may be irrelevant for some Chinese hospitals. Okay, so based on the interview findings, we developed an evaluation framework applied to Chinese hospitals. To evaluate the various ASP-related protocols implemented, three main categories should be considered. First is the upfront and ongoing investment associated with ASP activities in personnel and equipment. Some items involved are listed here as examples under hospital personnel or equipment. And for ASP impact, both clinical and economic outcomes should be evaluated, such as for clinical outcomes, IV to oral switch rate, antimicrobial resistant rate, hospital on-site infection rate, mortality, etc. And for economic impact, beside the resourcizations mentioned, all the costs associated with those resourcizations, and also monetary benefits or cost savings associated with favorable clinical outcomes should also be considered. Okay, followed by phase one, we constructed an economic model shell in Excel based on the conceptual evaluation framework. And first we populate the model with published and also some hypothetical data due to the data gap in Chinese literature. So as you can see, this is just an example of the model result page. And please, no need to pay attention to the actual numbers since we used some hypothetical data and also mixed data sources we used. And also we listed the ROI calculation equation here. Okay, so after that, we also developed a user-friendly graphic user interface tool. So the GUI tool is actually an iPad app and can be downloaded at the Apple Store. So the user-friendly GUI tool can be used for demonstration, customized analysis, and data collection. And these two screenshots here show the cover page and also the kind of like a TOC page, table of content page. So the user can click on those icon and then get into each detailed page. It's very easy navigate. So here we have several screenshots from this app. And as you can see it covers all the key dimensions mentioned previously for the evaluation framework. Just give you some time to just take a look, and so it covers basically covers the investments and also all the HE and clinical outcomes, and also include ROI analysis result page. So currently we are in the phase 4 stage. So we're going to collect data from 6 hospitals from 4 cities in China using the user-friendly data collection tool. And then once we got the data, we'll conduct economic evaluation analysis, focusing on the right side of this slide. We listed all the key analysis endpoints for this phase 4. So eventually we're going to calculate the return on investment and obtain some clinical measures and economic model analysis results based on real-world data collected from Chinese hospitals. And also we are going to conduct sensitivity analysis by applying reflecting the ranges reported by hospitals and also ranges found from the literature. All right, so Maria, are we going to have this takeaway messages, or are we going to have a question answer section first?
Feel free to review your messages now. You'll also have an opportunity to wrap up towards the end of the webinar as well, as you wish.
Okay, thanks everyone for listening to our presentation, and we hope our presentation can help people understand what ASPs are and their benefits, and also learn about open access global education programs as Dr. Sima mentioned, and that support the development, implementation, and measurement of ASPs, and understand the importance of ASPs in the Chinese National Action Plan to reduce AMR, and also how industry, Pfizer is addressing those initiatives. And we hope also our presentations can help audience understanding of the importance of standardized measurement, particularly evaluating the clinical and economic impact of ASPs. And our example also gave you how to evaluate that from a business perspective. And also from our example, hopefully you can get some understanding of the methodology used to create an ASP evaluation framework for China, and also get acquainted with interactive tools that can be used to collect data and visualize your model and validate and communicate the model results. All right, and also the checklist. The checklist is a checklist for baseline program elements and interventions to be used across healthcare facilities globally. All right.
Thank you so much, Cindy. And thank you again also to the other presenters as well, Seema and Emily, for imparting some very practical considerations for those members of the audience who are currently building or improving economic evaluations within their hospital antimicrobial stewardship programs, particularly in China. This topic comes at an important time, as we found when developing the LHSN report on the subject. We noticed the research included some studies on the cost savings effects of these programs. However, there's a lack of research demonstrating the cost effectiveness and cost benefit of different program modalities in a robust and comparative manner. So as our presenters have highlighted today. Seema, you referred to some of the research LHSN has undertaken on the topic. So for those interested in learning more about this, I'll just highlight that our report will be released at WISH 2018, taking place in November in Doha. It provides an international comparative perspective of different hospital stewardship program compositions, a checklist for core elements for hospital antimicrobial stewardship programs, and that was referred to as CHASP just earlier in Cindy's last slide there, and potential strategies for handling common barriers to these programs. So if you'd like to hear more about the report, we invite you to follow updates on the WISH Summit and LHSN via our webpage and social media accounts. Now at this point, we'll open up the session to the audience for questions. Cindy, if you don't mind just showing us the next slide, that'll provide some directions. Oop, I guess, no worries. I have some directions here, but as a reminder, you can use the chat function by typing your questions into the question box in the control panel, or use the raise hand function. We welcome questions and comments, your reflections, along with your name and affiliation. So please do, we welcome you to introduce yourself when sending over those questions. Now, to start, Cindy, we do have a question for you. And this is regarding your framework and model. The question is, how much time was involved for the entire project from phase 1 to phase 4?
Yeah, it's about like 1.5 years so far, because we started that almost 2 years. Time flies. So the project was initiated actually in late 2016. So that's almost 2 years. Excellent.
So one other question building on that is, has the project been implemented in countries other than China, in South Asian countries as well?
As far as, yeah, I know we haven't really implemented in other, yeah, but maybe in the literature, I haven't really looked at it in the literature, but as far as I know, yeah, I haven't done in other South Asian countries.
But you can do it.
Yeah,
right,
definitely.
Cindy?
Yeah, definitely we can do it. It's probably follow the same methodology. You know, develop a country-specific model framework, and then yeah, conduct and then build a model to do that. So that's actually we are glad to present this methodology. It's kind of like this initiation, you know, hopefully that can be adapted to other countries. That's our hope.
Yeah, and I think our GUI, our app, was constructed in a way that can be easily adapted to other countries. yeah, just to add some, a little bit.
So just to clarify, Pfizer and PharMerit plans this for other countries, or this is something still in the works? This is just another follow-up question from our audience.
I think our GUI can be definitely adapted to other countries. Yeah, but the adaptation will be on need basis, I would say. But yeah, in theory, technically, I think it can be adapted.
Perfect, thank you so much. One other question we have here. Early in the presentation, you mentioned consulting experts about their antimicrobial stewardship programs. What would you say are the largest, the biggest challenges to Chinese ASP leaders when carrying out ongoing economic evaluations?
So Emily, I can probably start, and you can feel free to jump in. I feel like one thing is a lot of, first, as I mentioned in my presentation, a lot of experts are very busy, and they probably don't have a lot of time to really try to learn about this. Is really to learn about the economic aspects of the evaluation. They are experts in terms of clinical evaluation, but to add some economic aspects, that's something, more educations or trainings are needed. So that's one of the challenge during the interviews we conducted.
Thank you.
And I think in addition to that, the knowledge about AMS programs is disaggregated across China and across many countries. So first you have to get everybody on board. Even before you start getting them on board about the economics, you have to get them on board about, okay, there is a problem, there is a growing resistance problem, and it needs to be addressed.
Yeah.
Excellent, thank you. We have here another question. Just one moment. And this comes from Robert Shelby, Director of the ISPOR Asia Consortium. For countries that don't have hospital-centric healthcare delivery, specifically primary care provider gatekeepers, how can antimicrobial stewardship programs get greater traction and specifically in a managed care environment?
So I'll start, and then maybe Cindy and Emily, you can add. So I think one way is to target maybe some of the organizations, some of the societies for physicians in the various countries, and just start raising awareness through those channels, and maybe even government programs or channels.
Yeah, I agree. I think at least for China, I think really government guideline is critical for hospitals. Under a certain system, each universities, academic teaching hospitals, all those big hospitals. Like if the government issue a guideline, that could definitely push ASP to be implemented.
Yeah, and just to add something, I think ASPs can be a very complicated program, but if we can find a way to start from small, from those low-hanging fruits, like using DDD, something that is easy to compare before and after an ASP, and probably we could easily see the effectiveness of this program, and bit by bit, I think that might be a good evidence to convince the hospital management team to start doing more on the stewardship program.
Excellent, thank you. Our next question comes from Kylie McIntosh from Safer Care Victoria in Australia. She's mentioned, you've mentioned that antimicrobial sales contribute to hospital income in China. How do you deal with this challenge when trying to reduce antimicrobial use as part of the AMS program?
So I believe you can tell me, but based on the interview, we asked the same question, but now it's a trend. Like there are a lot of series talking about this. So hospital, they won't, usually they won't say that, not at least not willing to say that. So they still pay a lot of attention to, trying to decrease the mortality or the resistance rate. So they still, their hospital evaluation indicators. So they do have some incentives, and there is a reform regarding disease or diagnosis based reimbursement system is ongoing. So hopefully that will change very soon. But I just want to say the hospitals are usually they don't really say that explicitly, and they do have cognitive evaluation, for their quality assessment. So they can't really only focus on their revenue or income. So they still need to pay attention to the clinical outcomes, which actually give them incentive to implement ASP.
Yeah, I agree with you, Cindy. Yeah.
Just a quick follow-up on this subject. Does China have the equivalent of a Center for Disease Control, as we see in Europe and UK and the US, and or a national patient safety agency to help lead these efforts?
Yes. Yeah, Emily, you want to, definitely they do have, entity equivalent to CDC, disease.
Yeah, definitely we have CDC in China also. So I think our Chinese healthcare reform is putting more emphasis on quality of care in hospitals. And coming back to the previous question, I think the revenue on antibiotics is becoming less important than the quality of care. And I think there's definitely more incentives to help the physicians to improve the quality instead of looking at the pure revenue on the antibiotics. Yeah, and I think in China there is a very huge problem on antibiotic misuse. So I think the ASP will have a very positive impact on containing the use of the misuse of these antibiotics. And I think this is the whole point of why Pfizer is supporting ASPs in China. Yeah, regardless of the loss of revenues, the possible loss of revenue.
Thank you so much for that. We have another question from Liz Sang Shi. The question is, how do antimicrobial stewardship programs differ across different levels of hospitals? Each level of a hospital has its own challenges in implementing antimicrobial stewardship programs. I believe that's a question. How would these four pilot hospitals, how would, I think, the findings of these four pilot hospitals be generalized to other settings in China, especially in primary care health systems in China?
Yeah, I think that's a very good question. That's why, we are constantly collecting data. So it's really, it's a very, it's an initial step. So we trying to, as you mentioned, or whoever, present the question, ask the question, like actually, we are going to kind of like compare different hospital models, operational models, based on those the pilot study results. I think that's very reasonable question, because we actually we expect the level ASPs across hospitals will be different.
Okay, thank you so much. We do have just a few more questions. One relates to the funding of this project. Would you be able to say a little bit about that?
Sima, well, actually, this project was funded by Pfizer.
Perfect. Thank you for clarifying that. Now we have a question from, just one moment. We have lots of questions actually. So bear with me as I just go through them. So we have a comment here from Five. He says, it's easy to do research in the US and work on antimicrobial stewardship programs, but it's far more difficult to do it in developing countries like Pakistan, as I have worked on surgical site infections, but unfortunately found higher rates. But hospitals are not allowed for interventional studies, so what do we do? No interventions have been allowed now that I've moved to China, so it would be easy for me to work on antimicrobial stewardship programs here. Do we need some clarifications on that question?
So,
yeah,
I'm not sure. So the
Cindy, I can start if you want. So okay, so if you're not allowed to do interventional research in hospitals in Pakistan, then perhaps, you know, one way to approach this in a country like Pakistan is once again through, you know, through associations or through teaching facilities, universities, where healthcare professionals are being taught, and also through impacting, you know, through the government channels, through policies, to try and change some of that. It's not going to happen in one day. It's a long process, but it's something that you can look into. Now, I'm not sure what's meant by, you know, they're not allowed to conduct interventional research. Are they not allowed from the industry? Are they not allowed at all? You know, is there perhaps a channel through which academics can do that in hospitals? So these are some questions that you can consider.
Thank you so much, Seema. So our final question relates to the GUI, and the question is, can it be used to collect data, or is it just done through your ongoing data collection? Probably within the Antimicrobial Stewardship Program.
Sorry,
yeah.
So are you talking about the current study for the data collection section?
I believe they're talking about the tool that you've presented, Cindy.
Okay,
the
so
GUI
that
tool.
Yeah, for the current study, the GUI tool is used as a demonstration tool, you know, to our physicians and our hospital administrators to show them the concept of the model, the evaluation, and the key components. So it's more like a demonstration tool, and then they can help them to understand what we are doing in the economic inputs and outputs, and they can play with it by changing the, you know, those model inputs and see the results immediately. Yeah, so that's a part of the data collection tool.
Perfect. Thank you so much. As we approach the end of our session, I think maybe we can offer you the opportunity to leave the audience with just a few additional messages. Do you have any additional comments that you'd like to make? Perhaps we've covered it all. We did have a good number of questions. So really, I'd like to take this time to thank our speakers again, Cindy and Emily and Seema, and again to also the director of the ISPOR Asia Consortium, Robert Shelby, for contributing to the programming of today's webinar. And also to our audience, we hope that it's been a fruitful webinar, and thank you for joining today. Just as a reminder, recordings of this webinar will be available on our website at www.leadinghealthsystemsnetwork.org. LHSN is also on social media, so please feel free to follow us on LinkedIn, Twitter, and YouTube, where you can access the new webinar announcements. Prior to ending this webinar session, I'll leave you with an invitation to attend our next webinar, on Thursday, the 18th of October, with Dr. Caroline Maslow and Dr. Daryl Vine, who will be presenting on antimicrobial stewardship at scale in Southern Africa. And they will be exploring ways to move past a low-hanging fruit antimicrobial stewardship program model to provide a world-class stewardship program. To sign up for these webinars, visit the LHSN website and look for 2008 webinars. So with that, we conclude our session. And on behalf of LHSN, we wish you a great day and hope you will join us again on the 18th of October for our next event. Bye-bye.